Welcome. I'm speaking to you today from Northern Ireland, where we have an amber wind alert. So if I disappear and stop speaking, it doesn't mean that I've been blown away to Oz. It means we've lost power, which could happen. We have a plan B, so don't worry about it. I'm going to talk to you today about one of the most challenging questions in all of ophthalmology, which is how do we go about screening for glaucoma, particularly in low resource settings? This is the disease that is actually my subspecialty. It's the second leading cause of blindness and the leading cause of unrecoverable blindness in the world. And yet, it's tough. We don't have great answers about how to identify the condition. So I'll talk to you about how Orbis is approaching that problem, talking about a couple of projects, one of them in Vietnam, one of them in Eswatini, Southern Africa, the first of which has been published already, and the second of which we've carried out some hot off the presses data analysis to share with you today. So novel glaucoma screening models in low resource settings in Vietnam and Eswatini. So just by way of disclosures, the study was funded by the Sidra Foundation. I'd like to thank Malik Kahuk for that, with earlier support from Shova, Excellence in Ophthalmology and Vision. The cameras and AI were provided by Remedio, as utilized in the described work, and we have no other conflicts to report. I'd also like to acknowledge my co-authors, including colleagues at Brace Vision and Eswatini, Dr. Jonathan Paz, Ms. Joanne Chesson, and our two graders, Hobsile Lukele and Sima Malanvula. At Orbis International, Dr. Hunter Cherwick and Noah Whitestone, and then colleagues at the University of Colorado and also the University of Ibadan in Nigeria. So it's a global crew that has brought you this work. And the first question I'd like to ask you, and we'll get these answers in real time, I'd like to understand, are you based most of the time in Africa, Europe, Asia, Latin America, or other? And there we go. So 30% Africa, 9% Europe, 47% Asia. Fantastic. So taking lower middle income countries as being Africa, Asia, and Latin America, we're looking at about 85% of you are in the settings that we're talking about today. So that's fantastic. I'm delighted to see that. Are you involved in glaucoma screening activities? So a third of you don't do screening. 40% of you are doing screening in clinics only. Only about 5% are doing community only. And then around 1 in 5 are doing clinics and communities. So about a quarter of you are doing some community screening. And I think this is most relevant to that. However, nearly half of you are doing screening in clinics, and this could be relevant there as well. And I should mention that all the tools we're talking about today are available to you for free right now if you're in a lower middle income setting, which 75% of you are. So this is all real stuff that you can use. For those of you who are involved in glaucoma screening, which we decided was about 2/3 of you, what are the biggest challenges? Insufficient funds or lack of equipment, not having the money, doctors having insufficient time, so not having the time, patients do not attend at the screening site or do not complete referral from the screening site to the hospital. This would include patients that are coming in already blind in one eye or both eyes. That's patients not attending at the screening site. And here we go. Half of you are concerned about lack of funds or equipment. I'm delighted to hear that only 1 in 5 of you think that the doctors don't have enough time. So that's terrific news to hear that 80% of you do have the time to do this. It's great. We're going to tell you how to do it now. About half of you are also concerned about the patients coming in late. So what we're going to talk about today, I would say, is quite relevant to all of these concerns because we're looking at things that are inexpensive, that don't take up a lot of doctors' time, and will help us to get to patients before they come in blind. So all of those issues can be resolved with what we're going to talk about today. So background, I think most of you probably know, the number of people living with glaucoma is going up steadily. And most of that increase is coming from Asia and Africa, which is where most of you are. And that's because Asia and Africa are growing in population and are aging very quickly. Most people with glaucoma don't know they have the disease, and so screening is crucial for detection. People, as many of you I'm sure have found out, if you wait for them until they're symptomatic, that first symptom is going to be blindness in one or both eyes, and that's too late for us to do much. So we need to be getting out there and doing screening as best we can. Interestingly, for many years, decades, we've known that screening for glaucoma is not cost effective in rich country settings. We published a paper about 5 years ago in Lancet Global Health, though, that showed that screening for glaucoma is cost effective in lower middle income countries like China. And it's simple. That's because the time of physicians is less expensive in those settings than it is in Europe and the US, and because the risk to patients is much higher. In high income countries, patients tend to be picked up when they come in for glasses or whatever, and that rarely happens in lower middle income country settings. So we know that in the settings like where 75% of you are based, screening for glaucoma is likely to be cost effective. The problem is we need models that are usable to be able to take advantage of that fact that screening is cost effective. So I'm going to spend nearly half my time today talking about some foundational work that we've already published that came out a couple of years ago in Vietnam. And then I'll spend the rest of the time talking about brand new work that we've just completed analysis for within the last couple of days in Eswatini in Africa. So in Vietnam, we previously developed and tested an online course to train non-ophthalmic graders to screen for glaucoma during diabetic retinopathy screening. That's how we decided to do it to begin with. And many of you could take advantage of that. If you have an existing program that captures images of the back of the eye, you could do what we did and train those graders or new graders to look for glaucoma in those images. I'll talk a little bit more about it, but I want to say right here at the beginning, the course that we designed takes about 5 or 6 hours. It's self-paced. You can do it whenever you want to do it. It is available for free online in Cybersight. So you can do all the things that I'm going to talk about today yourselves if you want, provided that you're based in a lower middle income country. So we taught these folks to screen for glaucoma during diabetic retinopathy screening, and then we compared their post-training performance against ophthalmologists, local ophthalmologists. So it's an uncontrolled interventional experimental before and after study. We had 43 non-ophthalmic DR image graders. These folks were not, any of them, ophthalmologists. None of them had any kind of ophthalmology background. They were trained to screen for glaucoma using optic nerve photos. We looked at their performance. We created a little test, and we looked at their performance before and after training. And then after training, we compared them with local ophthalmologists who didn't get any different training. The idea was we wanted to see, can this course get people who are not in any way familiar with the eye to recognize glaucoma accurately after 5 or 6 hours? And after the course, as a way of a kind of gold standard to understand how good they get, are they as good, better, worse than local ophthalmologists? This was all done in Vietnam, so we're talking about Vietnamese ophthalmologists here. The training set consisted of 3 modules, and it was presented on the Orbis Cybersight learning platform, and it is still there. After it came out, it was the second most popular program on Cybersight. So it's already had quite a lot of use, but we encourage all of you to use it as well. The optic nerve photos that we used to create that course came from 3 different sites. One was the existing Orbis Cafe diabetic retinopathy program in Vietnam. We wanted to expose the screeners to some images that they might be familiar with from their local setting there in Vietnam. Some of the images came from a UK population study. So we wanted to look at population representative images to look at the kind of glaucoma that might just walk in through the door. But importantly, images not from Vietnam, but from the other side of the world in the UK. And then finally, we got a bunch of images from the Gone online training set. That is a training set of images available out of Australia. And what's cool about it is thousands of different users have tried that out and have compared themselves against gold standard graders. And what that means is that by using the Gone images, we could know which images are easy, medium, and hard. So we could see if our graders before and after training were finding the easy images easy and the hard images hard. That kind of thing is a kind of external validity that helps us to believe that our study results are real. So we had a script. There was a voiceover in this training, and that voiceover was in Vietnamese. So we translated the voiceover into Vietnamese, and then we translated it back into English just to make sure that the translation was accurate. But of course, the course itself, being in Vietnam, was delivered entirely in Vietnamese. The ophthalmologists didn't take part in the course, only the non-ophthalmic graders. We were taking the ophthalmologists as a kind of gold standard, and we assumed they already knew what they were doing. So in terms of the test material, we assessed learning in the course by administering a quiz to all the graders before and after training. That was our fundamental way of understanding whether they had learned something from this course or not. The graders were shown two images, one from each eye, of so-called patients. And again, coming from Vietnam, coming from population-based studies, and coming from this teaching website. They had to make a single choice, refer or don't refer. That's basically what we're looking for from a grader. Someone's going to decide somebody more experienced than me needs to look at this or not. If they chose to refer, then they had to say why. And just to be clear, this course was trying to teach people the same kind of stuff that those of you who are ophthalmologists and optometrists presumably learned about recognizing glaucoma during your training. Recognize what cupping looks like, a high cup to disc ratio, a cup that's quite large, larger than it normally should be, a cup in the middle of the optic nerve that extends all the way to the edge of the optic nerve, a pretty reliable sign of damage from glaucoma. Cupping, damage to the optic nerve, that's asymmetric between the two eyes. It can be hard sometimes when we look at just one eye to say, does that person just have a normally big cup, or does that person have glaucoma? Comparing the two eyes, if we find big differences between the optic nerves, that's much more likely to be glaucoma. We tend to be pretty symmetric as human beings. And then disc hemorrhages and other things, basically. So they learned all those different things, and then they had to select based on what they were looking at for each set of images. If they decided to refer, what was their reason for making the referral? That was the basis for the score, was the getting a number of points for getting the referral correct, and then having to know why the referral was made, if it was if they thought it was needed. And as I mentioned, the optic nerve images that we had from the Gone training website, which were 23 out of about 60 that we had, were separated based on how previous trainees had done into easy, moderate, and difficult as a way of kind of looking at the external validity. Are we getting results that make sense compared to what we know about the world? The results by graders and the general ophthalmologists were compared to the gold standard. We have 5 fellowship trained glaucoma specialists who are our gold standard in doing this work. So let's take a look at the results that we have so far. This just compares, it shows how the ophthalmologists and non-ophthalmic graders compared. And looking in the right hand, those of you who have done a little bit of statistics see all of these p-values are pretty high. So there were no statistically significant differences between these groups. But let's talk about what we did see. We found that about 2/3 of the ophthalmologists were over the age of 30. We found that about half of the non-ophthalmic graders were over the age of 30. We found that about 3/4 of the non-ophthalmic graders were women, but only about 60% of the ophthalmologists were women. Still not a significant difference. In terms of looking at the ophthalmologists, we're all ophthalmologists, 29 of them. And here we can see that the non-ophthalmologists graders here break down basically more or less half and half into nurses and other physicians. And by other physicians, we're mostly talking about endocrinologists, people that are caring for people with diabetes. Because remember, these images were, these graders were people who are already working on grading diabetic retinopathy in this case. And we can see the work experience is pretty similar between the groups, 7 years versus 8 years. So pretty comparable. So let's look at the accuracy here. And there's a lot of numbers. So let's start with the simple stuff, which is the total down here at the bottom. This is really kind of the bottom line, literally. So here, hopefully you can see my pointer. Before getting training, the graders, the non-ophthalmologists, only got about 1/3 of the questions right. They doubled that score up to about 60 after the training. So a huge improvement in performance with training. And then looking here after training compared to the ophthalmologists, we see there's no statistically significant difference. So if you don't remember anything else about the work in Vietnam, I want you to remember those two things. Taking an Orbis course, self-paced, 5 hours, people who had very little background in the eye, had only learned how to do DR grading on nurses and endocrinologists and stuff, doubled their scores and performed just as well as local ophthalmologists. So it's a pretty impressive result right there. The other stuff to look at is that irrespective of where the images came from, we got the same result. So whether they were GON website, Vietnamese DR program, or this population-based study, we still had a very significant improvement with training. And we also had no difference between the post-trained graders and the ophthalmologists across a whole different variety of places where these images were from. So consistent results all the way across. And then finally, from the standpoint of whether these data behave the way we think they should, remember we've got easy. So they did a little better on the easy images. They did a little worse on the moderate images, and they did the worst on the hard images. So I would say everything here has turned out just the way we would hope that it would turn out. Let's look at a little more detail about what it was about the grading that improved. And to do this, I'm going to have to teach you a little bit of statistics. So you have to bear with me. Sensitivity talks about the proportion of people that we find that we correctly identify who have a disease. So in this case, before the training even, the graders could, out of 100 cases of glaucoma, they could find 85 of them. It's not bad. You would think, boy, that's great. That's all we need. Why bother training them at all? They're already right 85% of the time in terms of identifying cases of glaucoma. The problem is this. When we do a big screening project like this, obviously we want to be able to accurately identify people with disease. But what's even more important in the real world is that we need to have good specificity. Specificity means that I can correctly identify someone as normal who is normal. So I should be able to tell someone who does not have glaucoma, you're fine, go home, have a nice life. If I incorrectly tell that person, I think you've got glaucoma, I have wasted a lot of resources. Someone is coming in for a more detailed exam who doesn't need it. And potentially, I've got a bad name in the community. A lot of people come in and say, they told me to go to the nearby hospital and get a test, but I didn't need it. I turned out not to have it. So, what kills a screening program is bad specificity. We end up wasting money and we end up creating a bad reaction in the community. These guys, the graders, the non-ophthalmic graders, before their training had terrible specificity. It was worse than 50%. It was like flipping a coin. Literally, we could have had a kid come in and flip a coin. After their training, they were up at 80%. That's the biggest improvement that these guys had. They learned not what glaucoma looks like, they learned what normal looks like, and they got really good at identifying what normal looks like. In fact, we look down here and compare the ophthalmologists, specificity among the graders after their training was actually better than the ophthalmologists. So that's really encouraging. What we really have to have for a good program is good specificity. And after training, we got these graders up to better specificity than local ophthalmologists. Very encouraging. We do see that the local ophthalmologists had better sensitivities. They were better at picking up disease, but they were not as good as recognizing normal people. And the ability to recognize normal people and send them home without wasting their time, that is the essence of a successful program, and that's what these graders had learned how to do. Positive predictive value, we'll come back to that when we look at the Eswatini results. This is positive and negative predictive value are not so meaningful here, and I'll tell you why. Positive and negative predictive value depend on the prevalence. So if you screen for a really uncommon disease, I don't know, let's just say uveitis secondary to tuberculosis infections. No matter how good your test is, your positive predictive value is going to be low because that's a really uncommon disease. In this case, we decided what the prevalence would look like, right? We created a test set that had some normals and some abnormals in it. So the positive and negative predictive value don't tell us a whole lot. Not very helpful to know. This AUC, the area under the curve, though, is kind of the gold standard. This is how we summarize if someone has done a good job of screening. And what's encouraging to see here is these guys, area under the curve before training was not good. After training, it was almost identical to the ophthalmologist. No difference. So very encouraging. When we look in a little bit more detail, we see that what these guys learned how to do from their training was to improve their specificity, crucially what we need to do to have a good screening program, and they actually got even better than local ophthalmologists in doing it. So looking at this in detail makes us even more encouraged and excited about the result of this 5 or 6 hour self-paced program, which you yourself can access if you want for free on Cybersight. So this is looking at predictors of correct scores. What were the things that really mattered? A univariate analysis means we looked at a bunch of things separately. Multivariate means we looked at them all together. When we looked at all the predictors together, it's interesting. The biggest predictor of getting good at recognizing glaucoma among these non-graders were two things. First of all, the pre versus post training. So huge improvement there, highly significant. But then the other thing was having less than 5 years of work experience. Strongly predicted a grader who learned to grade really well. And my apologies to those of you with white hair like me, but this probably is telling us that it's hard to teach an old dog new tricks. That's what it probably means. When we say that those with less work experience did better, that's probably suggesting that they hadn't built up a lot of bad habits They were relatively new to the game. They were more able to learn from our training how to properly recognize glaucoma. So take-home messages from the Vietnam study. First of all, participation in this 6-hour self-paced online course allowed these nurses, internists, non-ophthalmology types to double their scores on a test consisting of optic nerve images from all over the place. So simple course, self-paced, free, doubled their performance, and their post-training results did not differ from those of local ophthalmologists. Not only did it double their performance, it got them to a level that was comparable to local ophthalmologists in terms of their ability to recognize glaucoma. And these results were the same, whether it was coming from this GON repository, whether it was a population-based study, or whether it was the local DR program in which these graders had been participating. So that is the takeaway from the first half of my talk here. So to segue into the second half, in Vietnam, to finish up Vietnam, we thought, I wonder if we could do even better. That's already pretty good. But we gave these guys, these graders, these non-ophthalmologist graders, gave them a test. The test allowed us to figure out their weak points. What if we brought them in and gave them one-to-one training from a glaucoma expert, focusing on the areas that they had performed badly on during the test? Could we get them even better? And I have to tell you, a very encouraging result was that no, they didn't improve any further. It seems as if this low-cost course maximized grader performance. Very encouraging because, one-to-one training is expensive and difficult, whereas having people log on for free to a free online course and do it whenever they want, that's free. So this free approach worked just as well as a much more expensive approach of doing one-to-one training. So all of this, I want to be clear, this was all basically done on a computer screen. Okay, this was all done in a lab, if you will. We wanted to know, what if we took this approach into the real world? Could this work as the basis for proper glaucoma screening? We were funded, very thankfully, by the Sidra Foundation and Dr. Malik Kahuk to carry out a study in Eswatini, Southern Africa, to assess this training model as training module as part of a full glaucoma screening model. Now, before we go any further, I just want to say, I'm sure many of us are thinking, in 2025, why are you bothering to train humans? It's all about AI now. Fair enough. But there have been a number of studies recently from settings like China that have suggested that in lower middle income countries, it may not be true that AI is more cost effective than human graders. In fact, human graders in the China study coming out of Shanghai were more cost effective than AI because AI can be expensive and because human graders are generally less expensive in lower middle income country settings than they are in high income countries. And of course, training local graders is also important because it gives us a kind of human standard against which to compare AI systems that we want to use. So if you're wondering why we Orbis are continuing to train human graders in 2025, bear with me. We'll talk about that a little bit more. But that's part of our reason is we think that human graders, because they can be really cheap if we train them this way, can still be highly relevant in low resource settings. So where is Eswatini? This, not this big green thing, that's South Africa. This little red thing, that's Eswatini. Eswatini used to be called Swaziland. Those of you who collected stamps in your youth like me, maybe have heard of Swaziland. It is about 80 miles by 120 miles. Not a big country. It has a population of only around 1 million people. It is a relatively poor country. So that gives you some background on Eswatini. What were we trying to do in Eswatini? We wanted to assess the accuracy of screeners trained using this same Orbis course to identify glaucoma in the real world now. We were going to take this out of the laboratory, off the computer screen, and actually look at images that they captured in occupational health clinics. And we'll get to that in a minute. Why would we go to occupational health clinics instead of into the hospital where we do most of our work or out into the community? We wanted to find out whether AI consultation could improve this. So the Remedio cameras that we used, and Remedio is sponsoring today's talk, also offered a free AI consultation. So you'll see how we did this. But we wanted to know, can AI, when it's used in consultation as a kind of a helper for these graders, can it improve their performance? We also wanted to know about other aspects of this real world program. We wanted to know what the follow-up rates were of referred patients. Even if the graders are doing a fantastic job of picking up people with disease, if those people never show up, doesn't do us any good. So we thought that was another important part of assessing if this model could do what we wanted it to do. And finally, we wanted to calculate the cost per true case identified, a measure of cost effectiveness. Is this worth doing? I'm going to talk to you about those first two results, how well the graders did, whether AI improved it, and what the follow-up rates were. We haven't analyzed these data far enough yet to talk with you about the cost effectiveness. That'll have to be our next webinar together. So the rationale and the setting, why do we choose to go into these occupational clinics? The challenge in Africa in particular is to identify patients early, to avoid that classic phenomenon. I see quite a number of us today are from Africa. Then you know if you see glaucoma patients. The classic presentation is somebody comes in blind in one eye. They've been blind in an eye maybe for 6 months, 2 years, whatever. And one morning they wake up and the sheet or the pillow or the puppy or their kid is covering their good eye. And they're suddenly saying, oh my God, I went blind this morning. And so they come in and obviously they've been blind for a while, but they've just discovered it. We want to avoid that by picking people up earlier. But people, not only in Africa, but of African descent in the Caribbean and other places around the world, they get glaucoma a decade earlier than people of European descent, a decade earlier. So we need a screening setting that will get us access to younger people. And that's why we chose workplaces, occupational clinics, younger people, working age people. Not only is that getting us a convenient way of accessing younger people to catch glaucoma earlier and potentially save vision, it also maximizes the potential economic impact because we're getting people who we know are working. Occupational clinics then allowed us to piggyback our screening on outreach activities in a bunch of different workplaces that were carried out by a company. This commercial service is hired by different companies and they go around every day to a different company. Company pays them and they come in and they offer a bunch of different exams, blood pressure, blood sugar. It's a perk for their workers, makes the workers happy. They're very happy, these clinics, very happy for free to let us go ahead and piggyback on, bring in our glaucoma screening. We think this is a pretty nice model to screen for glaucoma, particularly in settings like Africa and East Asia, where people are getting glaucoma earlier and maximize the economic impact. It's cheap and easy. There are some downsides, and we'll talk about those downsides in just a minute. So in terms of methods, graders, training, we partnered with Grace Vision, which is a hospital in Eswatini, and 5 applicants who had no medical background of any kind underwent training on the Cybersight course, and then they took our test. And the 2 applicants with the highest score were hired. So that could be a useful way if you guys wanted to implement a program like this in your own setting to do just what we did. They don't have to be people you don't know. They could be people who are currently working at the front desk or as drivers or whatever in your facility. Offer them the test, offer it to whoever wants to take it and use that as a way of choosing the people who score the best. The initial screenings were carried out exclusively in workplaces, as I just mentioned, going from factories to a variety of different settings, farms, everything. Um, Subsequently, we added some additional settings such as churches, because we wanted to bring in some older participants and increase our yield of cases. I'll talk about that a little bit more, but there is a reason that we tend to screen older people for glaucoma because the prevalence of glaucoma is higher in older people. Screening younger people for glaucoma may make a bigger difference in the sense that we may have the chance to pick them up early enough to prevent blindness, but there are fewer of them, not quite as many. We'll look at in a minute again at how that played out. So the grading course and test were exactly the same as what we used in Vietnam, except in English instead of in Vietnamese. And as I mentioned before, they focused on the appearance of the optic nerve, assessing the cup to disc ratio. Our cutoff was greater than 0.6, asymmetry, notching, disc hemorrhage, all the things that those of you who have been trained as an optometrist or ophthalmologist learned during your training. In terms of screening, the trained non-medical graders captured images of the back of both eyes with these Remedio cameras for everybody who felt like being screened in the workplaces and churches and other places they went into. So here, unlike what we did before we just trained graders to look at these images, now these graders are actually looking at the images that they themselves are capturing. So this human screening thing is a one-stop shop. These guys are going out with a camera, they're doing the image capture, then they look at the image and they make the call themselves as to whether the person needs to be referred for glaucoma. Just like what we did in our first study in Vietnam, which was kind of a pen and pencil thing, here in the real world, their initial decision was refer or not. That's all they had to decide. These people should get an additional, more detailed exam from an expert, or they can go home and go on about their lives. Now, the cameras, as I mentioned, these Remedio cameras have an automatic AI review feature. And the graders were made a subsequent referral decision based on this feedback. So what this means is the first thing is that the grader had to decide, had to commit and say, without having looked at the AI, here's what I would do. And they had to write that down, enter it into a computer, done. Then the AI feature came and the grader saw that and they could either change their decision or not. And then anybody with a positive grade, that is positive on the grader alone or the AI assisted, would be referred in. We also referred a 10% random sample of people who screened negative. This is a little bit of extra for experts, but let me try to explain this to you. We wanted to measure sensitivity. We wanted to know how good these graders were in this real world setting on images that didn't come from a website or a study, but actually came from their own images they had just taken. We wanted to know their sensitivity. We wanted to know what percentage of people that actually had glaucoma that they could pick up. Now, if we only looked at the people that they thought had glaucoma, we couldn't know the sensitivity. We couldn't know if they missed anybody. If I only do my gold standard exam on people that you think have disease, I can't tell if you missed anybody. So we took a 10% sample of those that they thought were normal and examined them as well, trying with the sole purpose, trying to find out, did they miss anybody that had real glaucoma? And if so, how many people did they miss? So the referral, those that needed referral were referred to a nearby site and they got visual field testing with an Oculera headset-based system. Just for a minute, there's a bunch of new ways of measuring the visual field out in a field setting, out in a community setting. And these are potentially a game changer. Oculera is one of those. It's a headset. It's basically a VR setup. And these VR setups come from video games, and so they're cheap. These video game things cost a couple $100 instead of $30,000 for a visual field machine. And obviously, because they're head mounted, because they're used for playing video games, they're very easy to carry around. And then finally, a lot of them have pupil tracking. And so instead of telling somebody when you're testing their visual field, always look at the center um, and just try to notice when a light comes and then tap a button with your finger. When people are using an Oculera, another one of these headset systems, we watch to see if they look at the light. And that looking at the light is the sign that they saw the light. And it's much easier than having to tap. So these headset systems are fantastic. I think they're going to revolutionize how we do visual field testing in the real world, in the community. Then there's also some that are done off of computer screens, and we did some of that testing as well. So these guys got visual field testing if they were referred for possibly having glaucoma, and they also got assessment of the intraocular pressure. Then all the data, including the fields, the pressure, and the actual images that we recorded from the video or from the camera, were reviewed by an ophthalmologist, Dr. Jonathan Pons at Grace Vision, and a final diagnosis of glaucoma, normal or suspect, was made. So for the purposes of us trying to assess greater accuracy, if the ophthalmologist said they either had glaucoma or they were suspect, that was considered to be a correct referral. So to date, we have enrolled 2,500 participants. That was what we set out to do. We've done it. We are still analyzing some of those data. Among 138 people who underwent referral as glaucoma suspects, 75% have completed the referral visit. So that's our first very encouraging result. In this setting, because we put the referral center nearby, 75% of these people showed up, and we're trying to get the rest of them to come in now, text messaging and things like that. So that's very encouraging. 75% showing up is real good, better than most programs. Of those reviewed by the ophthalmologist, 30 cases of glaucoma have been confirmed so far. So why is that number so low? Almost 3,000 people, only 30 cases of glaucoma. That's about 1%. Again, we focused on a very young population to identify people who are at real risk of going blind in their lifetimes. If I meet somebody with modest glaucoma at the age of 75, my intervention is to shake their hand and say, congratulations, you're never going to go blind from this disease. It's the people we're picking up, young, 30, 40, 50. They're the ones who are at risk. There are fewer of them. They're harder to find. Not everybody's going to go blind from glaucoma, but we believe that targeting these working age people makes sense. We need to do a fuller cost effectiveness analysis and really look at this. But I think it's a valid question. Finding fewer cases, but finding them among young people who might really go blind, I think that may actually be a more sensible activity. And our data confirmed this was a really young group. Looking at those that we screened, the median age was 42. That's young. That's way, way younger than most screening groups that we look at. If we look in a hospital, if you did this in your clinic, willing to bet you your average glaucoma clinic patient or even your cataract clinic patient is a lot older than 42. And the ones we found with definite or suspected glaucoma had a mean age of 52. Those are still pretty young people. Those are people with a real risk of going blind during their lifetimes over the next 20 or 30 years. So what did we find about greater performance? Sensitivity was actually better than what we saw above in Vietnam. With the train, well, let's look down through here. Specificity was 88%, almost 90%. Remember, I told you that specificity was the most important thing, and this is better than what we saw in Vietnam. So in this real world situation of capturing and looking at their own images, these guys did fantastically well in specificity. Really good job of only referring people in with glaucoma. Their negative predictive value is very good. And area under the curve, 86%, that was also better than what we saw in Vietnam. So in this real world situation, they actually did better than the folks looking at perfect idealized images in Vietnam. Now, our positive predictive value doesn't look so good. And why is that? Remember, I told you positive predictive value depends on prevalence. The prevalence of glaucoma in these workplace settings from young people was low. It was only about 1%. So it's not surprising that the positive predictive value was not super high. That's still pretty good, though. 60% of the people they wanted to send in ended up having glaucoma or glaucoma suspect. That's actually a pretty encouraging result. When we look across the line here, this is the trained grader with AI consultation. We can see the sensitivity went up a little, specificity went down, positive predictive value went down, negative predictive value went up a little. Area under the curve, the overall summary was pretty close. So I would say we don't necessarily, if AI was expensive, we wouldn't need to add it in. These human graders are already doing pretty well. If we didn't have human graders, it looks like the AI could probably do a pretty good job as well. So I think this is an interesting result and one that we can interpret in a number of different ways, depending on what kind of a program we wanted to do. So conclusions to date, referral follow-up is pretty good among glaucoma suspects in this setting because we set up convenient sites for them. Really encouraging, 75%, a very good number. Sensitivity and specificity values of 80 to 90% are very encouraging, with nearly 90% specificity, which I've told you is the heart of a really successful screening program. It avoids wasted resources. These cadres with no medical background and folks where there was basically a zero training cost, right? It's a free online self-paced program. They're very inexpensive cadres. This is a pretty inexpensive, cheap way to screen for glaucoma. The use of AI consultation didn't appear to improve their performance substantially. That's just how we decided to set up our program. You might set up a program that uses the Remedio AI to do the screening yourself and might do a different approach. But we found in this setting, the graders already did quite well without needing to consult the AI. And workplace screening does appear to be effective in identifying younger patients. We've got to figure out if getting this smaller number of younger patients who are really at risk of going blind, whether that's the most cost-effective way to go after glaucoma. It certainly could be a part of an overall program. So that is that. Vietnam, Eswatini. Do only developing countries face this issue? I would say that this issue of glaucoma is faced by all countries, not just low resource countries, lower middle income countries. To be clear, though, in high income countries, we miss about 50% of glaucoma. About 50% of glaucoma is not known. The other 50% just gets picked up when people come in for glasses tests and things like that. It has been shown in high income countries that work like what I just showed you, programs like what I just showed you, are not cost effective because it's very expensive to screen for glaucoma in high income countries because eye doctors are very expensive. Now, maybe if we used an approach like the one I've just talked to you about, that might make it cheap in high income countries, but all the work that's been done up until now has suggested that it's not cost effective. But it is cost effective, our work has shown in Lancet Global Health, to do outreach screening for glaucoma in lower middle income countries because the cost is less and the benefit is more, because 90% of glaucoma in lower middle income countries does not get picked up. People are not getting picked up when they go in for glasses or whatever. So I would say, to answer that question then, scroll back up to it, the problem of glaucoma exists, and the problem of missing glaucoma exists in rich countries and in poor countries and in middle income countries. But the approach, the outreach screening approach, makes particular sense for developing countries. So hopefully I've been clear about that. And now we've got, I am Garcias Endue from Liberia. Good afternoon. And I think we've got several questions. So I'm not sure. Okay, so these are sort of underneath here. What about people who don't understand English or Vietnamese? Okay, so that's a good question. Currently, we have this course available in English and Vietnamese. If you think it should be in another language, we're creating new language versions of our courses all the time. Vote for what you would like. I'm just going to make a wild guess from your name that maybe you'd like to see it in Arabic or maybe French. But contact Cybersight, and at the end, if you have any clinical questions regarding today's, we invite you to send them to us via. Okay, good. So in the chat, it says how to get in touch with Cybersight. Not just clinical questions. Also, please send them if you say, "Gosh, I'm really interested in this course, but my native language is Arabic or Urdu or French or whatever." Send that to Cybersight and let them know. And we're always translating new courses into other languages. So let's see. How Isa has just said, "I'm happy to be here," and how I am also happy to be here. I'm very happy to be here. Let's see. If you didn't understand, you will still get a certificate. Okay. Okay. It's a pleasure to be here. More interested to see programs like this. Fantastic. Well, we look forward to seeing more programs like this as well. From Radad Fati, how do healthcare contexts of Eswatini and Vietnam differ? How do these differences affect digital innovation strategies? Good question. So, several things. Asia has got a higher higher population density, and has got, generally speaking, a better developed transportation infrastructure. Eswatini, as part of Africa, generally has lower population density and a less well-developed transportation infrastructure. So outreach screening is more challenging in settings like Africa. And so we prefer in settings like Africa to try to find places where groups of people are already together in one place. And that's why we went to occupational clinics, workplaces, churches, things like that. In Asia, if you want to do a program like this, you could potentially just literally go to communities. You could go to villages, and population density is high enough, transportation infrastructure is good enough that you could potentially do that. You could do that kind of outreach screening. We have to be a little bit more clever about that screening in Africa and try to go to places where there's a lot of people already together in one. That's why we chose the occupational clinics, which I do think can be a good approach, as long as you're open to the idea these guys will be younger and you will have to do more work to find patients. So also, Radadi Fatih would like to know what lessons were learned in Eswatini can be applied to Vietnam, vice versa. I would say that in Eswatini, we learned that this works in the real world. And so I think that can be applied, that fact can be applied. We could now go back to Vietnam or back to Asia and say, we think this can work in the real world. That's the most important, I would say. And potentially that screening younger people might be an effective strategy of capturing people who are really at risk of going blind. What we learned in Vietnam was that you can teach people who are currently doing DR screening to do this work. So let's imagine that in your country, you have a large DR screening program at your hospital, let's say, that screens 50,000 people a year. You've got those images. You've got people that are already looking at those images. You could use the Orbis course and teach those graders in looking at those images to also pick up the people with glaucoma and make that a more efficient and productive process. So I would say we had some learnings from each side that could be applied to the other side. I'm going to keep scrolling down. Another from Radadi Fati, who has a lot of good questions. What future digital innovations could further strengthen glaucoma care in low resource settings? Gosh, there's lots. I will tell you one thing I'm very interested in is the question of Now that we have visual field machines that are cheap and easy to carry around, I mean, if you can carry a video game, to school or work or whatever, then you can carry a visual field machine, right? Because these new VR headsets are basically based on video games. Um, so that means that we can take visual field machines now to the countryside. We are doing work in India, China, other settings, various settings, to try to find out whether adding visual field testing on top of looking at the images, either with AI or with human graders, as we did here, does the visual field add anything in terms of picking up patients? We're looking at that right now. I think that is a potential way in which we could further improve the outreach screening that we're doing. And we're just trying to find out if that's a cost-effective and useful thing to do. And of course, AI is going to get better, better, better all the time. How can governments or NGOs support scaling these solutions nationally or across similar countries? Again, from Radati Fati. So NGOs can do kind of what Orbis has done to create sample programs, to do research, to create models for scaling up. NGOs have relatively small budgets. NGOs are not going to generally not going to do screening across an entire country, but they can show, as we've done in these projects that I've shared with you today, how a model could work. Governments then come in and do the screening, the national screening. A government, for example, could say, we're already doing diabetic retinopathy screening. We know it's cost effective. We're committed to doing it. It's part of our diabetes national plan. And we know that diabetic retinopathy is the leading cause of blindness among working age people. We think that makes it a really cost effective thing for us to be doing. A government could then say, we're going to add glaucoma in. We see how cheap it is to do. All we need to do is have our graders attend this self-paced online course, and they can add glaucoma screening into the existing DR images that they're looking at. So those are some examples of how this could work. How do I access to the GONE images? The GONE images, have a look at our paper that was published about Vietnam. Look up, my name, Nathan Congdon, under glaucoma screening in Vietnam, and you'll find on that paper it'll give you directions about how to get in touch with the folks who do the folks at GONE, and and I'm sure they'd be very happy to share their images with you. That's what they exist for, is to do training like this. My question is that in cases where signs suggest more than one possible diagnosis, what is your preferred method for systematically narrowing down the differential? Well, that's a good question. That's a pretty broad question too. I would say my usual method is this. I want to know what is more likely to cause blindness, and I'd like to know what is easier to treat. So if I see somebody with cataract and glaucoma, I might be tempted to go after the cataract, as long as the glaucoma is not really bad. But if the glaucoma is in a young person or really bad, that's the thing that's going to make them go blind. Then you've got to go after the glaucoma. So, which of these things is more likely to cause blindness? Which is relatively easier to treat? That's the basic basis, which of course is mapped out across a whole bunch of different diseases. But that's how I would generally think about it. So the example, if somebody has glaucoma and cataract, I would say, okay, generally speaking, I'd like to do the cataract operation because that's going to give that person immediate improvement in vision. But is the glaucoma really bad? If the glaucoma is really severe and doing the cataract operation might cause blindness for the person, that means that the more dangerous potential for blindness is glaucoma. So that's broadly how I would think about it, to answer your question. Art mentioned the role of optometrists. So there are about 10 optometrists in Vietnam where we did this study to begin with. Not a lot. It's becoming more. That's a bit of an exaggeration, but it's very, very few optometrists still. That's a new profession in Vietnam. So there weren't a lot of optometrists at the time when we did this study, and that's why. Nothing against optometrists. It's just not. But it's the graders aren't optometrists. The graders were mostly nurses and internists, and a few of them were endocrinologists. But the reason we didn't have a lot of optometrists is there are very few optometrists in Vietnam. They've only recently begun having training programs. So that's the answer. That's our reason to answer Abdul Salam's question. Then Raja Huzaifa would like to know any China MBBS graduate or student of MBBS. I'm not exactly sure what that means. I guess he wants to know if anybody else around here is like that. And I couldn't tell you. I can tell you that I lived in China for 10 years and I speak Chinese fluently. But I couldn't tell you if there's any Chinese MBBS graduates or students here. But there are bound to be plenty of people like that. And I'll tell you what, if you want to get in touch with me, Nathan Congdon, they can tell you what my email is. I will put you in touch with someone I know from Somalia who got an MBBS in China, if you want to talk to her about it. Can this training be free for nurses in Europe, UK? So that's an interesting question. I would ask the Cybersight folks how that works. I don't know the answer to that. In general, our Cybersight program is available for free for folks that are in lower middle income countries. But there's got to be some way of accessing it if you're in a high income country. So I would use the information that they've given you in terms of, Andy, let's just make sure it's out there where people can see an email address to ask those kind of Cybersight questions. And I would encourage this person to ask that question. I'm sure there's a way of getting it. We designed this course to be free. It should be free for anybody. I'm sure we can sort that out if you contact Cybersight directly. Good evening from the Philippines, and good evening to you too in the Philippines, a lovely country. I used to get invited annually to the Philippines for their annual glaucoma meeting. Cybersight, please tell me, is there any webinar related to Meditech separately? Again, Raja Huzaifa's question. Let's just make sure that we have prominently indicated somewhere a place where people can reach out to Cybersight to ask their questions. Then Kakendra Basnet is asking, what are the challenges that healthcare systems face when implementing digital tools for glaucoma detection and monitoring? Okay, so number one, approval. Governments have got to approve these digital tools. Orbis is in the process right now of getting digital tools approved, AI tools for use in diagnosis of glaucoma and diabetic retinopathy in South Africa. So approval is a challenge. And then cost is a challenge. Orbis makes these things available for free, but that's obviously not always the case. And even if Cybersight is available for free, you got to buy the camera in order to be able to take the images. So I would say cost. In terms of training, doctors are expensive. Hopefully with our model here, you can reduce that because you can train people who are relatively less expensive to train. Anonymous attendee, why Eswatini in Vietnam? What made you choose them when there are others also available? Well, there are, 207 different countries in the world. And, we could have gone to any of those 207. Why do we choose those? We chose Vietnam because Orbis has an ongoing large diabetic retinopathy screening program. And our initial question is, we thought it'd be interesting to find out whether we could readily add glaucoma to that. So that's why we chose Vietnam, because of the existing Orbis DR screening program. We chose Eswatini because we wanted to go to Africa, and we had a collaborator there who was ready to work with us, who was interested to do glaucoma screening. So both of these were targets of opportunity, I would say. We're always looking for other opportunities to do collaborations with folks. Please suggest questionnaires for glaucoma screening. Thank you so much. So I guess what I would say is I'm not sure that questionnaires are great for screening for glaucoma. That's what I would say. I would suggest if you want to screen for glaucoma, you might start with using our training course. I think that's a pretty good way to start. It's cheap, and you don't have to have AI. You do have to have a camera, though. You have to have a camera. Um, and you could graft it onto an existing DR program, which is, pretty cheap to do. But I don't think you can screen for glaucoma with a questionnaire because most people don't know they have glaucoma. And so there's no question you're going to be able to ask them that will accurately identify if they have glaucoma. People do screening for diabetes all the time with questionnaires, but I don't think you could do it very well with glaucoma. Anonymous attendee, based on screening methods in Eswatini, why set the referral rate 10% from random sample of negatives? Good question. The purpose of doing that was for research. We just wanted to know how good our sensitivity was. We wanted to know how many how many glaucoma patients, how many glaucoma people our graders were missing. And the only way to do that was to send in a pretty good sized number of people that they thought were normal so we can find out how many they were missing. And doing that helped us to see that their sensitivity is pretty good. It's around 83, 84%. It's really pretty good. So we chose that 10% because we knew there were lots more normal people than there were glaucoma people. And even 10% of normals would give us lots of normal people to estimate what this sensitivity was. That was our reason. Doc, did you consider to incorporate OCT? So we didn't consider to incorporate OCT. We wanted to try to make this as cheap as possible. The cost of the camera, 3 or 4,000 US, I think. I'm not super up to date on OCT, but portable handheld OCT, what that's going to be 20, 30, 40,000 US probably. My impression, and anyone who knows this better than I do, feel free to correct me, but my impression is a portable OCT, which is what we would need here, of course, is going to be about 10 times as expensive as a lowish cost camera like the Remedial. So that's why we wanted to try to keep this as cheap as possible. I'm not saying OCT isn't good. I'm saying that Orbis is particularly interested in cheap solutions that can be effective in low resource settings. OCT is generally not a part of our paradigm for that reason because of the cost. Once it comes down in price, sure. And then Abida Tasneem would like to know, gosh, I wish all of you could put in what country you were from. Some of you have, because I'd be fascinated to know where you're all from. Abida Tasneem wants to know, does the general population-based screening program for glaucoma lead to a reduction in visual impairment or eye blindness compared to standard care like a case opportunistic case finding? So great question. I think the answer is, Abida, yes, it probably would. If it was good, if it was well done, but it would be expensive. That's the problem. If we go out at the general population, particularly if we're going in the community, going from place to place, especially in an African setting, that's going to be expensive because it's expensive to get into the community where the population is very spread out as it is in Africa. So I would say that general population screening for glaucoma does appear to be cost effective in China. And yes, I think it would lead to improved reduction of visual impairment compared to opportunistic case finding in clinics. So I believe the answer is yes for Asia, where the population is pretty densely together and you've got good transportation infrastructure. We've answered that question for China. I have questions about whether it would be true for Africa. I'm guessing it might not be true for Africa. And for Africa, we don't have to just wait in clinics. We can go opportunistic by going to workplaces and some of these workplace-based clinics like we did in Eswatini. I think that could be a good approach for Africa. There may be other approaches that we could think about together. Now, Maud Bodza has identified, I assume herself, as being from Ghana. Please, apart from fundoscopy, where you get to view the disc using the isn't rule to make a diagnosis of glaucoma, assuming one doesn't have a tonometer or other tools to confirm, but have to make a diagnosis, what do you do? Okay, so fundoscopy or direct ophthalmoscopy. You could do direct ophthalmoscopy. That's not going to give you an image. You're not going to get depth from that. Besides fundoscopy, the other approach could be to um, do cameras. So a low-cost camera. And if you think about it, once you factor in the time of an ophthalmologist to do fundoscopy or an optometrist to do fundoscopy, it may, and in many settings, I believe it is cheaper to go out there and do the screening with the camera. So that would be my response to Maud from Ghana would be that the best way to get hold of those images to do the disc screening with the isn't rule might be to do low cost image capture using low cost cameras like the Remedio camera that we used. Then we've gone on to anonymous attendee. How can we screen glaucoma without proper instruments? Is there any other procedure? So I would say the instrument that you need at a minimum, I would suggest is a camera. So I think you can screen for glaucoma with a Remedio camera. I think that this test, the study, shows that that can work pretty well. But if you're going to do that, then you have to have some way of getting those people to where the definitive test is going to be happening. And you have to have some way of treating them. But I think this approach with just a low-cost camera, with images being graded and taken by people with no background in ophthalmology, that's probably the cheapest way to do it. That's a pretty cheap way to do it. So, Christmanith Gardira Pierre, sorry, would like to know, what does it mean to have suspicion of glaucoma? Broadly speaking, suspicion of glaucoma means the optic nerve cup to disc ratio is kind of on the edge. It looks like it might be glaucoma, but it's not obviously glaucoma. Or the pressure is high, but the person doesn't have optic nerve findings suggesting glaucoma. Or the person has a visual field that looks like it might be glaucoma, but it's not absolutely diagnostic. So it's somebody who has a result that's kind of on the edge. Or somebody who has pressure that's high without any of the other signs of glaucoma. Those would be the classic things that give me a suspicion of glaucoma. What risk factors contribute most to early onset glaucoma in Indian populations? Well, genetics seems to contribute in a pretty important way. If you have a relative who's a first degree relative with glaucoma, that's an important risk factor. The problem with that is if you're in a rural setting, nobody knows that they have glaucoma. So a first degree relative is not that helpful. Information about the family is not that helpful in rural settings where most people haven't been diagnosed. Elevated intraocular pressure is an important risk factor for glaucoma. Having a thin corneal thickness, a cornea that is thin, that is a risk factor for glaucoma. Even having a large cup to disc ratio without being definitely diagnostic for glaucoma, that is a risk factor for glaucoma. So I would say those are some of the classic and important risk factors. And of course, age, being old, like me, is a risk factor. Being of African descent, that is a risk factor for glaucoma. But those, obviously, the African descent one is not relevant in India, but age is relevant in India. It's relevant everywhere. Then Mahfouza Tasneem would want to know, hi, Mahfouza from Bangladesh, one of my favorite countries in the world. I was just in Bangladesh for a visit. I have a question. How can we make sure digital innovations in glaucoma care doesn't just reach communities, but actually changes their health outcomes, especially in places where technology arrives faster than trust? Boy, that's a power-packed question, as I would expect from someone from Bangladesh. So first of all, we have to make sure that the technology is used not just to do screening, but for treatment. So there has to be treatment available. That treatment has to be accessible for that person, and it has to be affordable for that person. So I think that's a big part of it. And then you're right about trust. Yeah, there has to be a way in which we have built up the trust of those patients to accept care where it's being done. And part of that is to improve the quality of care. People in rural areas aren't stupid. If the care is better quality, they're more likely to be willing to trust and take it up. So to actually change outcomes, we reach communities. It sounds like when you're saying so, when we reach the communities to change the outcome, then the key, it sounds like, is acceptance of service. That's the missing piece. And I would say, yeah, improving the quality of service, spending time answering questions that the patient might have, that can improve their uptake. Trying to offer free transportation, reduced transportation barriers can help with uptake. And some education explanations can improve uptake. All of those things. Reducing price also improves uptake for sure. Then Fatima Mahmoud is asking, thank you for your time. How does greater performance compare to AI over time as trainees gain more experience? My best current master's student is named Fatima, and she's from Pakistan. So greater performance, I would say that once these graders were trained, their performance didn't seem to change very much. So I would say we train the graders with this online course, and they take a test. They pass that test, they start working. It's a good point, though. We can look in this study that we've just done in Eswatini, and that's a note that we should take. Hopefully, someone will help to remind me if Noel is here or someone can help to remind me. We should do that analysis, and we'll try to remember to do that analysis to see whether accuracy of referral improved over time. I think that's a good question. I would say that if you really want to know if greater, it can improve and it can also go down. Sometimes you need retraining. So I think you have to test and see. We haven't seen evidence in the studies we've done that there's been changes. And in this setting, the only comparison we made to AI was that we found that AI used as an adjunct didn't improve accuracy. And we can look and see if that changed over time. That's a good suggestion. Now we have an anonymous attendee what is motivated to start a project like this in lower middle income countries? Well, so what motivates Orbis to do this is Orbis is founded as an organization to try to save sight, improve lives by saving sight. And we know that glaucoma is a crucially important cause of sight loss. Orbis is really interested to come up with better models to improve sight loss. So we did this because it's our organizational it's our goal. It's what we exist as an organization to try to do. Why do I do it personally? Because I believe what Mencius says, that all humans possess the heart that cannot bear for others to suffer. And so that's why I became a doctor, and that's why I do this kind of stuff, because it bothers me to see people go unnecessarily blind when it's not needed. And that sort of spark in me that Mencius talks about, and all of us who became doctors, is what drives me to want to do this, because it bothers me to see people lose vision when they don't need to. Okay, and we have someone from South Sudan who's introduced herself. Welcome. Great to see somebody from South Sudan. How can an optometrist contribute in glaucoma screening? I believe that optometrists are just as important as ophthalmologists for glaucoma screening. I hope that nothing that I said today suggests otherwise. We didn't include optometrists in these studies in Vietnam because there are so few optometrists there. I believe that optometrists can learn just as well as ophthalmologists to recognize glaucomatous optic nerves and to do an important role. And I would say, as a glaucoma specialist, I believe that in most settings, it's appropriate for optometrists with appropriate training to provide treatment for glaucoma in terms of medications. So I believe what you're allowed to do as an optometrist varies from country to country, but as an ophthalmologist and glaucoma specialist myself, I believe that optometrists can contribute in those important ways by diagnosing and treating glaucoma. And I recognize that may vary from place to place. So I'm not trying to tell anybody's laws how they should be, but in broad general terms, I do believe that optometrists can play those roles where they're permitted legally to do so. Unity Mengui, who does not tell us where she, I'm guessing, or maybe he is from. I've been working on an ophthalmology unit. How can I use this knowledge to engage in community eye screening so as to reduce the burden of visual impairment in my community? I would suggest, Unity, that you could download this course for free and find some individuals who are interested to do some screening and try to find some resources to support their time. It doesn't have to be tremendously expensive. This project was done for a few tens of thousands of US dollars, not a tremendously expensive project. And a lot of that was around research. I think this could be done for quite a bit less money. So I would suggest download the course, train some people who are inexpensive, whose time is not expensive to do the screening, and then send those people to capture images. You're going to need a camera. Send those people to capture images at places that are inexpensive to go to and where people are already gathered together. I would suggest that workplaces or occupational clinics might be a good choice. Just going into the community can be difficult unless you're going to a church or some other place where there's a lot of people together, or unless you've got chiefs or mayors or other people that are effective in getting the community to come together to get a lot of people screened at one place. Screening is difficult for disabled people or people with multiple disorders. How do you screen such patients who can't maintain their balance or understand how to be for screening? So that's a good question. I think that we can potentially capture images for those folks. I believe that there are cameras that are capable of doing that. There are cameras that come right off of a smartphone. What I would recommend is to use a kind of handheld camera like that to capture accurate images. Try to get the camera so that it's based against the person's forehead and not moving relative to the person. It has to have a cone or a supporter, something else that stabilizes the camera against the person's head, and then something else that's stabilizing the person's head. If the person is seated in a wheelchair, they can come and put their chin in a chin rest. If they're lying down, then try to support their head on a pillow or something like that. But capturing that image is the key, and capturing that image using whatever device you need to. If the person is capable to come to a slit lamp, they're in a, a wheelchair, then it's pretty easy to use something like the Remedio. If they've got to lie down, if they can't come up to a chair, then yeah, you got to stabilize the camera against their forehead and stabilize their head against a pillow or something to get good quality images, and then do the rest of the stuff we've talked about in terms of screening those images. Is there an organization supporting the glaucoma screening in areas of rural Kenya with training and equipment? Um, yes, I think Sight Savers might be doing that. I would try to get in touch with Sight Savers UK. I think those guys would be, I believe they're active in Kenya on this. So good. And then is there a pharmacist have a role in glaucoma screening? I believe that they can. Absolutely. I think that a pharmacist could take this course and in collaboration, you have to have a camera in the pharmacy there. But I think that absolutely there could be an important role. Absolutely. So digital glaucoma tools adapted to use in Vietnamese rural villages. I would say that kind of thing we've talked about, I believe could be used in Vietnam's rural villages. I believe that we could use something like the Remedio camera there to do this kind of screening. I hope you found something useful out of this. I certainly found it extremely interesting to talk to you today, to listen to your questions, and I would look forward to the opportunity to learn more from you in the future. So yeah, everything I talked about today should be available to you through Cybersight, this course in particular. Obviously, that course will need to be used in conjunction with some sort of a camera. We were very satisfied with the Remedio camera when we used it, and I'm sure you can find out more about how to access it. I don't mean to suggest it's the only camera available, but we found a useful camera. You could use the course that's freely available on Cybersight together with any kind of a decent low-cost retinal camera to do something very similar to what we've done. And it would be fantastic to have more of you replicating this in your own communities, in your own settings, including your own clinics, if it was useful. That includes pharmacists and optometrists and all of you. Good stuff. I think our work here is done today. Thank you all very much. And yeah, I look forward to the chance to chat again soon.